I think without any further ado, let's hand over to Professor Louis Appleby from NKISH to give us the latest updates on findings on self-harm and suicide prevention and updates related to COVID. So over to you, Louis. Would you like to share your slides?
Yes, thanks very much. Thanks, Emily. Hello, everybody. Let me just so you can do the usual thing. So this is where I just need to check with you that it comes up.
Yes, that's worked.
Great, thank you very much. It's always that that need for reassurance at the beginning of a talk. Hello everybody. It's good that you could make it. Good to see so many people have been able to come to the session. Just a reminder that these sessions historically start with an update on evidence. So I'm trying to update now since the last time the group convened, just a couple of months ago. And this is mainly today talking about some of the work either by or related to the function of the confidential inquiry. The inquiry's role in this national project is to support local suicide prevention with data and with evidence. That's what today is about, but also with calls, responses to queries, sometimes meetings. We put aside time for meeting for those who request it. But today is about updating the evidence. So to update, we just need to go back slightly because the dominant theme of suicide prevention remains the possible impact of COVID-19. And the question which has been around since the start of the pandemic, which is whether suicide would rise as a result. And it wasn't difficult to see why suicide might rise. People were anxious about the pandemic. They were isolated, cut off from potential supports, maybe experiencing a loss of people and services that they were used to relying on. There were economic pressures. There was an early rise in domestic violence. There's evidence that alcohol has been more of a problem for some. So there are plenty of reasons why we might be concerned about suicide and suicidal behaviour. And so in the confidential inquiry, we set out to monitor what happened to suicide nationally during that first period. And we had to do that because the usual system for measuring suicide rates in England, that's through coroners, through inquests, then registrations with the Office for National Statistics. That wasn't really suitable for such a timely monitoring that we needed. You will know that the time between a suicide death and the registration of that death is around 166 days. The median time, that is 166 days. So that was far too long to give us the kind of close monitoring of an emerging crisis or potential crisis. So you may know that we therefore called on this group, the STPs taking part in this project, to help us with the real-time surveillance data that they had already collected. We were able to collate the data from some areas, and the map there is showing the STPs as they then were that contributed to the data set. So we were able to monitor suicide during the course of last year, and overall those STPs, although it wasn't the whole country, it was a population of 13 million people, so a quarter of the population of England. It's a quarter of England, but it's actually bigger than most European countries. And we were able to compare the pre-pandemic months with the post-pandemic months. RTS is new, so we couldn't go back too much further, but it did give us a point of comparison. Okay, so and that in the corner there is the paper that we published earlier this year on the data. So you may know what the figures showed. The purple line is the published data. The orange line is unpublished data for today and other current meetings. So what we found was that the suicide rate in those areas in the pre-COVID months, let me just see if I can bring up a laser pointer here. So here are the pre-COVID months. There's the suicide rate in those areas, and then we moved into the COVID months. So marked out some of the periods there: lockdown, the immediate post-lockdown period, and then afterwards. And here's where the point where our previously published data stopped. And during that period, we showed no rise in the suicide rate, and this is sort of compared to this period here. And even these months where there was a degree of volatility and figures were a bit higher, that was not a significant rise. It's actually a relatively small overall rise. And the only difference on the graph is this point here, whether in October the rates looked like they had actually fallen significantly. So no rise in suicide in those early months. And since then we've carried on with your help monitoring the figures into what was then the second wave and beyond, coming out of it here. What we saw during that time, again, is despite some volatility in the monthly figures, there was no overall rise, no single month rise, no rise related to any period like lockdown or post-lockdown. And the most recent figures are following this pattern as far as we've got them analysed. So that's the overall story. And it's fair to say there was a degree of scepticism from some nationally that this could possibly be true, but it's been more or less confirmed by numerous countries worldwide and by our subsequent data. However, ONS, I mentioned ONS take much longer to get their figures together, but when they do, their figures go further than what we were able to publish. So this is ONS's report from just a couple of months ago now, but they're looking back into the early pandemic period. So it's using that early period as an indication of what we might be facing now. And they were able to do things that we weren't able to do. So on the one hand, they were looking at a very early period, much earlier than I've just showed you. On the other hand, they had much more detailed information. They were looking at the whole population, not part of the population. They were looking at at the official way in which suicide is recorded through inquests, and because of that they were able to compare with previous years. And what this slide is showing is that comparison year on year of official figures for those early months, and the purple bars here are 2020 compared to previous years, as you'll see. And this is broken down by age. They were able to break it down by sex as well. And what they found, the ONS's report was that they also found no rise, so they were essentially confirming what we had found. But in fact, they were being rather cautious because they found a small fall, and that fall was of around 5%. And in particular, the fall was more pronounced in men, and it was especially true of people under 25. So I'm going to say a word about young people in a moment, but just bear in mind that the definition of young people does tend to change from one study to another. So in this particular study, young people means people under the age of 25. So they quite contrary to what most people were concerned about. The suicide rate that they reported was a slightly lower rate, certainly no increase, and that the concern in young people was not borne out by their figures. They actually had another group who they were more worried about, and that was people over the age of 75. And this is both sexes combined in this graph, so it's not so easy to see the point, but they found a difference between males and females. And the one group who did not show a small fall, in fact a small rise, was women over the age of 75. Now, maybe this was just a statistical artifact. The actual numbers weren't all that high, so you can get rogue results when numbers are small. On the other hand, it is conceivable that there were stresses affecting older people, and older women in particular, that weren't so apparent in the rest of the population. The effect of isolation, for example, the loss of contact with families, the effect of bereavement and physical illness. All of these things could be conceivably a bigger stressor and therefore a greater risk to suicide rates than in other parts of the population. And it's worth bearing in mind that when the SARS epidemic hit in the early 2000s in the Far East, the group in whom suicide appeared to rise was older women. So there's a historical consistency there. Okay, but overall, ONS confirmed the general message that suicide had not gone up. Now, since then, the worry about young people has not gone away, and we've looked at young people with their disrupted education, with employment opportunities also very uncertain, and continuing economic uncertainty in the lives of young people in relation to housing and sustained income. We've looked too at the pressures of being confined in their homes with families. Some families are supportive, some less so. And in general, the young people have become the group around whom most concerns have been collecting. And here, it's a slightly busy slide, but let me just explain what it shows. Is one of the reasons. So now we're looking not at suicide, but at self-harm. And now we're looking not at 2020, but at 2021, or at least both years combined. And this is a representative data set from Manchester. And this is self-harm presentations in hospitals. So important to stress that this is hospital presentations. And it's showing, if you look at the green line there, that's the total number of presentations in A&E departments with self-harm in Manchester during this period. So here's the pre-COVID period I was talking about, and here is the early COVID period when suicide in young people seemed to go down. And in fact, there is a fall in self-harm attending hospital. Now, a lot of us thought, well, that's probably because people are staying away from the service. They've been asked to protect the NHS after all. It's found not just in this setting, but in a lot of other conditions. But maybe there was also something reducing self-harm risk itself. So a drop, and then towards the later part of the year, here we're starting to see a rise. And this takes us into the second, that dotted line is the second wave. And now it looks as if we're not really seeing the same fall that we saw in the first lockdown period, that maybe something is a little bit different here. Now there's a sort of a resetting back to normal levels, so a possible rise in certainly not a fall in the second lockdown. And then we get into 2021, where we see higher figures for most of the year, with the exception of this August period, which, don't forget, is the school and university holiday. So what looks like higher figures than the pre-COVID period now appearing during some months of the year. Now, okay, this is not conclusive proof, but it's raising a concern about that initial protection for young people may not have persisted. And you can see that it's mainly in girls. The grey line is girls, and the green line is total, black line is boys. I should say you get a similar pattern if you look at primary care attendance with self-harm. But this is now a slide from colleagues in NHS benchmarking. They do fantastic work recording the patterns of care in the NHS. And so this is one of their slides. And it's showing two very important things. First of all, it's showing the pre-COVID years. So this is referrals into CAMS, so the pre-COVID years, and you can see a rise, or more or less a year-on-year rise, in the number of people who needed specialist mental health care in the under 18 group. And makes a very important point that when we're talking about recovery from COVID, when we're talking about what should we be doing from now, who should we be worrying about, it isn't just the impact of COVID itself that we should be concerned about, it is also what was happening before COVID joined us and became part of our lives. And the pattern for young people was already a worrying pattern. It was one of a rising rate of suicide for the previous 10 years. It was a rate of rising self-harm, non-fatal self-harm rates for probably about 20 years. So, so here we are. This is reflected in these pre-COVID years. Now, this is 2020 when the numbers generally went down. But if you break 2020 and 21 down into months, so you've got the monthly referral rates, you can see that there's the initial drop that you saw on the previous slides, but and here is the a late 2020 rise. So this is around about the time of the second lockdown period, so confirming what seems to be a greater stress on young people, so higher self-harm rates, higher rates of referral into CAMS, dropped again, and then, as with the previous slide, back up into higher figures again during much of this part of this year. So again, nothing to prove that suicide and self-harm rates might go up, but just another piece of the jigsaw suggesting greater mental distress in young people. Possibly a bit of reassurance towards the end as the figures begin to appear to fall. So young people remain one of our biggest concerns. Who else? Well, this is an interesting study. You'll have heard us talk about it before, probably. It's conducted by colleagues at UCL. It's the COVID Social Survey. And it's a national survey which repeats every few days, where people fill in forms, questionnaires about their experience, about their well-being, about their behaviour, and it's giving us a picture of the well-being of the country since COVID began. And this is just one slide taken from that big survey, and this is on COVID stress. This is people recording COVID stress. And so you'll see the general pattern at the beginning of the pandemic: high stress in a lot of people, came back again during the second wave, but then dropped during the course of 2021, people much less stressed and anxious. But in recent months, it looks as if those figures have gone up a bit. And if we look now at this particular group, so bottom right, we can see that that was a common pattern in different groups, but the figures were different. So this is people who had a mental health diagnosis of some kind, doesn't necessarily mean secondary care, but similar pattern, but higher figures throughout. And just the possibility that more recently, a widening of the gap between the rest of the population and people whose mental health is poor. So a really important point, that if society opens up, it may not open up uniformly. It may leave some people behind, and those people, paradoxically, may be at greater risk because they're relatively less able to take advantage of the possible return to normal life. Now, this, of course, was before the current variant appeared to add to that stress. So I said in one of my first slides that it wasn't difficult to see why we might be stressed by the COVID picture, but what about looking into the future? Those stresses are not the same. They have changed, evolved, and we need to look at where the stresses might come from and the potential risks to suicide rates. Well, first of all, the big one remains the economy. If the economy does a serious downturn, that will almost certainly put up mental disorder and almost certainly put up suicide rates as well. And the graph is illustrating how that can happen. So this is an old graph of the suicide rate in England, which throughout the 2000s was the suicide rate falling, lowest point on record in 2006-07, and then the recession hit in 2008, and we saw a rise in suicide, which may not look huge, but at its peak was about 700 extra deaths per year. So it was a very substantial effect. And very importantly, it didn't all happen in 2008 and 9. It continued, and so the effect was long term. Once people are into an economic spiral downwards, that can continue in other ways. So job insecurity, unemployment, debt, loss of home, or at least worry about losing home, gambling, and so on. Further economic problems arise, and it was 2013 before the peak was reached. So any economic supports, and they have been substantial, those economic supports cannot be short-term if they're to have a suicide prevention effect. What else as we look into the future? Well, the arrival of long COVID, a new source of long-term physical disability, always associated with mental ill health, and potentially a stress towards for suicide rates. Problem of isolation being worse for some that I've mentioned, continuing disruption to services for some, and then the return to work. Maybe that's less likely in the short term with the new variant, but as more people return to work, they also return to the stresses that work gives. Work has positive effects on our mental health. For some, it has serious negative consequences, and people will return to that. And then there is this issue of whether how we return to normal. And I put that on the slide because I wanted to make the point about emotional weariness. If we still feel that we're into a further wave, that here we go again, then it may be that that in itself will be an emotional stress. You could argue that one of the protective factors early on was the sense that this was a crisis, a short-term crisis that we could just get through together, and then things would improve. But as that changes, there may be a kind of emotional weariness that is in itself destructive. And I just want to show you an interesting slide that's been study that's been carried out by ONS, where they ask people that question: when will life return to normal? And they've been asking it throughout the pandemic, and there are different options. And you can see that. So here's the very beginning. Here's the opening up in last summer. Here's the second wave, and here are the most recent findings. And you can see a big difference in how people are looking into the future and that issue of returning to normal. Initially, Most people thought it was going to be short term. Then that began to change. The green bar gets smaller and smaller. And now, even though we're 18 months on, people are still seeing at least another year before there is some kind of return to normal. And 11% of us think we will never be back to normal. 1 in 9 of the population thinks we will never be back to normal, which was hardly anyone's view at the start. So a possible increase in pessimism, a weariness about where this has left us. Okay, now I'm going to move off COVID just for the final couple of slides, just to mention 1 or 2 other publications that have come out. So this is a paper that we've published in the Confidential Inquiry, which refers to mental health patients, and it refers to ethnic minorities. And so it's you know how the Confidential Inquiry works, I suppose. We collect detailed clinical and social information on the circumstances in which patients die by suicide. It's a complete national sample, very large number of deaths, and we've been looking at figures of this kind for about 20 years. So we've published from our very large data set the information that was particular about ethnic minorities. It's not necessarily about risk factors. It's saying, what are the characteristics of people who die by suicide, and by implication, what are the prevention measures that might be most effective? And so the first finding of this study was that these factors differed between ethnic minorities. And it is time we moved away from the idea that we have one ethnic minority in this country, and that we have measures that will apply to all, because the characteristics and therefore the prevention priorities were different. So if we take South Asian patients, they were more likely to be with family, and therefore there's a possible route to prevention. They are more likely to suffer from depression, less comorbidity. So again, the treatment of depression, the support of families might be the main route through which suicide might be prevented in patients from that background. Whereas in contrast, if we look at Black Caribbean, Black African patients, we find that the main antecedent is serious mental illness, severe illness, psychosis and schizophrenia, often complicated by the so-called comorbidities, especially alcohol and drug misuse. So it's targeting those characteristics that would have the best chance for prevention. If we turn to some others, so Chinese patients, the most striking thing is that the majority of Chinese patients who died were female. And so that's a very unusual pattern in any suicide study, although it is also found in rural China. And what it suggests is that, again, a different approach to prevention, what looks like short, recent onset depression in female patients being the main target. Whereas if we look at people so-called mixed or multiple ethnicity, their pattern is different, much more like the majority white pattern, with people with social risk factors which separate them from support, but also high rates of known risk factors like self-harm and substance misuse. This group, a particularly important group, because in the recent ONS study of ethnicity and suicide, this was the only group that had a high suicide rate, multiple or mixed ethnicity. And finally, just last week, you'll have seen that we saw new guidance on depression from NICE, and it was interesting to see how it was reported, because it was mainly reported in the press as being a turning away from drugs towards therapy. Well, in fact, that turning away was in the 2009 guidance. It's a reflection on the way that society views this issue, that was the most newsworthy element, because it wasn't actually a feature of this report at all, or at least it wasn't a new feature. What was new? Well, I suppose first of all was the fact that this was the first revised guidance on depression for 12 years. So there, I think, is the first positive thing. But the second thing was that it introduced a much stronger element of patient preference. So the message was that certainly that drugs weren't necessarily the first line treatment, but that there were a number of possible first line treatments, and that was a matter not just for evidence and data, but also for patient preference. And so that bringing together of the hard data and how patients view their condition, it's that combination that takes us forward therapeutically. And you may have heard us say this before, but from our point of view, that is where research goes. The statistics, but also the personal stories and the personal preference. So that NICE guidance reflected that, and there's a whole range of therapies that might be made available through adopting NICE guidance. It said one other thing too, and that was it emphasised the importance in people starting antidepressants of monitoring suicide risk, and this was particularly true in young people. So a greater emphasis on the potential risks in the early period. I suppose the most important message of NICE guidance, though, is that a lot of people are still untreated. So getting any treatment is probably the main aim that we should have in mind. Thanks very much for listening.
Thank you very much, Louis. Amazes me how we hear from either yourself or Nav every other month at our learning sets, and all of the new data from yourselves at NKISH and other sources of data that you've got as well. So I was wondering if there are any questions for Louis. We've got just under 10 minutes or so. So any questions, please feel free just to unmute yourselves and go ahead, or pop your question in the chat as well. I saw a point earlier to clarify from Adele Owen, who asked whether Greater Manchester are included in the study that you mentioned at the beginning, the real-time surveillance.
No. So it's the reason for that is that we decided to at that phase, don't forget this is an ongoing study, but in that phase it was important to have whole STP contributions. So there are some very good real-time surveillance projects which are in partial STP areas. But there is a slight problem experimentally with including them, and that is that there might be a reason why part of an STP is collecting data and another part isn't, and that introduces potential bias into results. So we said we will have to set the geographical boundary ourselves. It can't be generated from the field, and the simplest one was the entire STP. So I'm sorry about that. It's not a reflection of the quality of data. It's a purely it's a sort of experimental thing to make sure that you're not introducing bias by saying, well, we'll take your data, but we know that your next door neighbours haven't got data. Adele, thank you very much for all your support in all of this anyway. We do appreciate it.
Any other questions for Louis? Chris?
Hi. Oh, I'm just move it so I'm facing the camera. Yeah, it was just relating to the RTS data that you had about that doesn't appear to be showing an increase. When was that? When's the latest we've got of that? I'm just very aware of that. That was a really powerful graph you showed of people's different perspective of how long we're going to be affected by COVID, and that was really dramatic, wasn't it? So I can imagine that and other things is going to have a real impact on comparing now with this time last year, I suppose. So I was just wondering what the latest we have, because I think that information you showed was still 2020, wasn't it? Or was it? I can't remember what it was.
The graph of our data, the actual graph goes up to April 2021.
Oh, okay, so it is later than I thought.
You're absolutely right to say we're always working with data behind time. But that graph goes to, so the initial publication went to October 2020, so that's in the academic paper. But what I showed today was some unpublished data, and that takes us as far as April. I gave a hint that the overall figures haven't really changed much since then, but that's not only unpublished but unconfirmed. So I'd like you to treat that rather cautiously. But your overall point is absolutely right, that we are always a little bit behind time, and so we're always catching up with what might have been in effect. It's just to do with making sure we've got reliable data. Self-harm figures though were more recent. So those self-harm figures from Manchester, they were taking us a bit further, and the overall figures are not showing very much change in self-harm. It's the young people's self-harm figures that we're most concerned about. So we've got a picture at the moment where the best evidence that we can come up with, although it is always a few months behind, is that suicide as a whole probably hasn't changed. At least we've got no evidence that it has. Let me put it that way. But the concerns are in a subgroup, and we've always said these are overall figures. they may hide quite a bit of variation between demographic subgroups, one part of the country versus another. So I don't think they're only a partial reassurance. They're not the whole story, and I think it's possible we may see more of that. So in my talk, I emphasised what we see as continuing risk for young people, and also for people who are under mental health care. I think even in the absence of confirming data, we've got to read the signs and at least be wary that they could still face a rise.
That's really helpful. Thank you. And I take your point about not publicising anything along those lines. But I suppose it's just useful to know if there is evidence of something, because there's always the worry, isn't there? There's something on the horizon that suddenly could change, and it's whether it's just being ready for that, as ready as we can be, if it should.
I think it is a really good point. Our view is, we get the most up-to-date data we can. We try to release it as early as we at the point where we can be confident. That doesn't mean it's proof or the final word or anything like that, but we want to have a certain amount of confidence in what we put out. And most of what we've been able to say so far has been about the lack of a rise. But there are just signs around, of young people. These referral patterns, which have been high since the end of last year, for example, for young people to CAMHS, and then you see the self-harm figures in Manchester, and so there just are enough signs about young people for us not to miss the early possibility, which we haven't got a confirmation of yet, just to stress, but the early possibility that young people's lives could still have more distress than we were picking up at the beginning.
And Keith.
Hi, Louis. Thinking about the young people's attendance at A&E in terms of self-harm, that could be, as was suggested, due to the increased distress and despair that young people are facing and how they're struggling with that. Two other possible scenarios come to mind, though. One is actually people are following the guidelines and making sure that if they're worried about a young person that's harmed themselves, they're getting the help required, i.e. following those guidelines, making sure they get the physical treatment, but also the opportunity of the psychosocial assessment. But another possibility on the more negative side is that services out there aren't able to be as responsive as they may have been previously, and therefore by default more people are coming to A&E than maybe being supported or helped in the other settings. So just variety of perspectives, I guess, and your thoughts on those.
Well, I think that's right, first of all, but also I think there's a general point here, which is that if we wait until we have proof that the figures for any group or in any part of the country have risen, then we will be a few months behind the time of optimum intervention, and sometimes you have to just take the chance that you might be intervening unnecessarily, and I think there's enough. So just to be clear, I'm not saying that the suicide rate has gone up in young people. I'm not even certain the self-harm rate has gone up in young people, but there are enough indications, just signs here and there, which if you take them together, have a degree of consistency, and just it's enough for us to adopt the precautionary principle and say, well, here the precautionary route is of greater vigilance and responsiveness and getting the messaging right and all of that. But I agree that there are other explanations, and we may well see a different pattern as time goes on.
Thank you, Lewis. There are still a couple of outstanding questions in the chat, and I think maybe a couple of hands up as well. So if you do have any questions for Lewis, I don't know if you're able to stay on for a couple of minutes just to address those questions in the chat, depending on your time.
Yes, I can do that. Yeah.